Hello friends, today we will discuss about obstructive sleep apnea, A to Z information. In local language it is called snoring disease or obstructive apnea. Okay, so I'll discuss all aspects and this video is especially made for patients and healthcare worker to sensitize them about OSA. So let's see further. So first we should understand why we are sleeping, how much we are sleeping. So everybody knows that we are sleeping on average 6 to 8 hours in 24 hours. Means we are spending around one fourth to one third of our life while sleeping. Imagine one fourth to one third part of life we are sleeping. And duration of sleep depends on age. If you see newborn, it take around 16 to 18 hours sleep. When baby is newborn, he's or she is getting for feeding or susu potty like that. Otherwise, he or she is sleeping. So she used to sleep around 16 to 18 hours. As age progress, sleep requirement is becoming lesser and lesser and lesser. In on average adult life, the requirement of sleep is around 6 to 8 hours. In old days, it reduces further. So in old days, after 65, around 6 hours, 7 hours is more than sufficient. So on average, everybody should get at least 6 hours to 8 hours of sleep for normal functioning of life. But this sleep pattern is different in different people. Some people like Modi ji, he requires less sleep. Some person like me require more sleep. So it depends on person to person also. But on average, for adult patient, 6 to 8 hours sleep is more than sufficient. So sleep stages, if we see sleep stages, sleep is mainly two types. Non-rapid eye movement sleeping, also called non-REM sleep, and REM sleep, rapid eye movement sleep. These two are the type of sleep. We all used to have these four type of sleep. So non-REM sleep, it has three stages: stage one, stage two, stage three. Staging is depends on how much depth of sleep is. If it is superficial sleep, it is stage one. Deep sleep is stage three, and middle one is stage two. Means neither superficial nor deep, in middle something. Okay, so deep sleep is means very deep sleep. If you call a person, he will not get up. ना हिंदी में घोड़े बेच के सोना, that is deep sleep. Superficial sleep is कच्ची नींद. Whenever you will make some noise, it will that person will get up. Superficial sleep. Rapid eye movement, it is a part of means deep sleep, but the muscle tone is lost. If you see small babies, newborn babies, if you lift his hand, you if you lift his leg, you can easily lift because the muscle power is zero. So in rapid eye movement, muscle tone is lost. So this is rapid eye movement sleep. So both sleep are important for our life. So when person get sleep, say for example at 10 p.m., so it start from N1, means stage 1 of non-REM sleep. Then it goes N2. N2 means stage 2 sleep. Then N3, deep sleep. Then REM sleep. Okay. So this cycle is going on, going on, going on. Each cycle is around 1.5 hours. So on average, person used to get 4 to 5 cycle in a night. Total 6 to 8 hours sleep. Okay. So what is the percentage? If we talk about N1, superficial sleep is 5%. Maximum 50% is N2, means medium type of sleep, neither superficial nor deep. Deep sleep N3 is 15% and REM sleep is 25%. So this is whole cycle of around 1.5 hours. So if you compare non-REM sleep versus REM sleep, especially N3. So N3 sleep, there is good dreams, good dreams. We are becoming king. We are getting job. Our children are happy. We are doing some. We are eating sweets. Like good dreams are coming in deep sleep. But in REM sleep, the vivid dreaming. Somebody is killing me. I'm fighting with somebody. I'm running. Somebody is chasing me. Somebody is shooting me. Vivid dreams is coming in REM sleep. Okay. So this stage of sleep is also changing with age. If patient is newborn, is 24 hours will divided equally in awake, non-REM and REM. As the age progresses, the non-REM part, sleep part is getting reduced. Okay. In sleep part, REM is getting reduced, non-REM is maintained. In old age, REM is further getting reduced. Non-REM is almost same. So as age progresses, REM sleep is getting decreased. You can see in newborn baby, muscle tone is very less because most of the time they are in REM sleep. But in old days, muscle tone is intact. Once you touch person, he will get up because muscle tone are intact. So less REMs. So this is distribution of each stage of sleep. So if you see whole night sleep, suppose person gets sleep at 10 o'clock, 11 o'clock, or 10 o'clock, he'll get up to 6 o'clock. So this is sleep cycles. As I told you, patient will first go in N1 or stage 1 sleep, stage 2, stage 3. This is deep sleep. This line is deep sleep, N3 sleep. Very good sleep. Sweet dreams. Then this sweet dreams sleep is getting reduced overnight. So once you sleep at 10 o'clock, there is much more of deep sleep. Then as night progresses, is getting reduced. Okay. In morning hours, there's no deep sleep. But if you see REM sleep, in night, when you sleep, it is very less. As night progresses, it increases in maximum at morning time. So that nonsense dream, like fight scene or killing or vivid dreams, they are much more on morning time. But night time is sweet dreams because deep sleep is there. So this is pattern of sleep of each person. Okay. So why sleep is important for us? As I told you, sleep is two type: non-REM sleep and REM sleep. So non-REM sleep is important for our health. In daytime, we are working in a job or we are studying, anything we are doing, our body cells are using, body cells are functioning. So they are getting tired. Some cells are they are dead. Some cells are not functioning. So night time when we are sleeping, our cells are recovering. The cells that got damaged that are recovering at night time. There is recovery of muscles. Then it important for physical health. Then third is that some hormone, that is growth hormone, is getting secreted in non-REM sleep. Means first one third of night when deep sleep is there, maximum growth hormone is there. So those child who are not getting sleep adequately at night, or those children who are sleeping late at night. Suppose they are sleeping at 12 o'clock or 1 o'clock because of TV, because of exam pressure, because of mobile, because of anything, or because of different lifestyle. These child, the growth hormone is less and they are not getting enough height. They are dwarf. Okay. So growth hormone is important for our health, our means height. So those children who are getting sleep at late at night, they are shorter in height. So this is important for physical health. Which sleep? Non-REM sleep. The function of REM sleep, it is for mental health. Okay. So in daytime, whatever skill work we are doing, we are thinking, we are doing work, we are thinking good thing, we are thinking bad thing, all processes is going on at night in REM sleep. Okay, so whatever thinking, good thinking is getting stored inside, bad thinking is going away. So you can feel whenever you get up in morning, you feel fresh. There's no conflict with anyone, because bad things are suppressed, good things are stored in our body. So garbage in, garbage out. REM sleep also help in memory learning. So whatever we are learning at daytime is getting memory in night time. Okay, so those children or those person who are not getting enough sleep, especially in last one third of cycle where REM sleep is more, their memory is less. They are not able to concentrate. They are not able to memorize things. So those children who are getting sleep at night late and getting early because of they have to go school, so they are getting up at 5 o'clock or 6 o'clock. So in that REM sleep is lacking, less REM sleep. There is less memory. So sleep is very important for our memory also, and also important for emotional mental functioning. So those persons who are getting less sleep at night, especially REM sleep, they are emotionally level. They used to get depression, anxiety, helplessness, all things they are getting because of less adequate of REM sleep. So REM sleep is important for mental health and of course for cognitive performance, skillful work where we require concentration, like operating some machine or we are taking lecture. So lecture we need intelligence. So REM sleep is important for these tasks. So non-REM sleep for physical health, REM sleep for mental health. So sleep is very important. Now coming to our topic, that is obstructive sleep apnea. So what is obstructive sleep apnea? Okay, so it is like a somebody's that pressing throat. So somebody is pressing throat, what will happen? The air will not go inside our lungs. Okay, so in this figure you can see this is normal. So air is going through nose, going here, 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 up to lungs. This is normal airway. What happened in OSA, obstructive sleep apnea? There is obstruction, obstruction at neck level because of tongue, because of palate. So because of obstruction, the air will not go inside the lung. It will go up to neck and it will come out. So there is no breathing, stop of breathing. Okay. So airway is blocked and air doesn't move through. So this is obstructive sleep apnea. Okay. So apnea means if there is complete obstruction of airway, means more than 90% flow reduction for 10 seconds. Complete obstruction up to 90% obstruction for 10 seconds. This is apnea. Okay. Hypopnea is 30% flow reduction, means airway is not completely blocked but 30% blocked for 10 seconds. Complete obstruction is apnea. For 30% reduction for 10 seconds with they drop in saturation, because if air will not go inside, body will not get oxygen. So oxygen saturation will drop. If 3% drop in saturation along with 30% reduction, this is hypopnea or arousal. A patient is having 30% reduction for 10 seconds and patient is getting up. Patient is having arousal. That is hypopnea. So apnea, complete cessation or 90% reduction. Hypopnea, 30% reduction with low saturation or arousal. This is apnea and hypopnea. So what will happen if somebody is having apnea and hypopnea? As I told you, if patient is having apnea, hypopnea, and patient is having apnea, if you imagine somebody is uh, pressing your throat and you will have apnea, there is no flow. So what will happen? For survival of a person, patient have to take breath. Okay, so there are two things. Either our thorax muscle will work, so there will be two things. Either our thorax muscle will work and push air out, so the neck will get open. So by negative intrathoracic pressure, the pressure will push the neck. So there will be more negative intrathoracic pressure. Or for relief of apnea, there will be arousal. So arousal will be there with apnea as well as with hypopnea. So repeated sleep fragmentation, arousal will lead to less sleep at night. When person will get less sleep at night, he will sleep in daytime more. The patient will have more daytime sleepiness. If patient will have more daytime sleepiness, there will be low quality of life. Patient will have tiredness, patient always sleeping, doing work and taking naps, and crashes, road traffic accident. You must have heard in news that some lorry is going and the driver get a nap and the hit the car. Okay, so many road traffic accident is caused by more sleepiness because of OSA. Okay, if somebody will not get sleep at night, daytime he will have low quality of life, more fatigue, and less cognitive function. The patient will not have enough concentration. Okay, and as I told you, the repeated hypoxia, oxygen will go inside less oxygen to every organ. So there will be problem in heart and brain. So because of less oxygen, patient will have hypertension, patient will have coronary artery disease like heart attack, patient will have heart failure, CHF, arrhythmia, and patient may have stroke, hemiplegia, stroke. Patient will have brain paralysis because of less oxygen. So how severe this problem is OSA? And patient may have diabetes, insulin resistance, the weakness of bone called osteoporosis, hypercoagulability, hypothyroidism. So all these problems are there because of obstructive sleep apnea. So we should not ignore. This is very severe disease. It give many complication, uncontrolled diabetes, uncontrolled hypertension, heart attack, coronary artery disease, heart failure, less quality of life. Many problems is there because of OSA. So we should not ignore this. So what are the symptom of OSA? How to recognize whether somebody have OSA or not? So nighttime symptoms. As I told you, patient will have snoring. So whenever there is choking of this throat, patient will have snoring like that. And because of snoring, patient will have that not spouse or wife or husband is not able to sleep. Patient will have increased frequency of urination. Patient will go washroom many times at night. Irregular breathing. Partner witness stop breathing. Partner will tell, husband or wife will tell that while sleeping, he is getting choking of that breath. Breath is getting stopped like that, like that. So patient stop breathing, then jerkily he wake up to take breath, like a witness stopping breathing. Night sweat. Patient will night sweat. Increased cough. Sexual dysfunction. Patient will not have good sexual function at night because of this one. Palpitation. Increase heart rate or decrease heart rate. Daytime symptom. When patient will not get sleep enough at night, patient will have excessive daytime sleepiness. Because of sleepiness, patient will feel tiredness, lack of energy, fatigue, early morning headache. If somebody is having early morning headache, we should think of OSA. Diabetes, memory problem, high blood pressure, anxiety, depression, learning difficulty, especially in children. If children is having poor performance in exam or class, then we should think of OSA. So what are the risk factor? Do everybody will get OSA? No. The risk factor. The risk factor is most important risk factor is obesity. That's why it's called obstructive sleep apnea, because obese person they used to have more neck muscles, neck mass. So that will cause OSA. Another risk factor is thick neck. So thickness, if somebody is having neck size of more than 40, then he will have risk factor for OSA. Or 17 centimeter, sorry, 17 inches neck, that patient will have risk factor for OSA. Enlarged tonsils, adenoids. So these patients used to have risk factor for OSA. Now, this mandible problem, lower jaw problem. If lower jaw is behind, push backward, this is called retrognathia. These patients, they used to have more OSA risk factor. Then prognathia, mandible is coming forward, jaw. These patients, they used to have more OSA. OSA. Other risk factor like gender, male patient, they used to have more OSA as compared to female patient. Genetic factor runs in family. If my grandparent is having OSA, I have high risk of having OSA patient. Macroglacia, large tongue, large peritonsillar narrowing, enlargement of soft palate, tonsillar hypertrophy, nasal septum deviation. It's not bone, nasal bone. If it is deviated, then patient will have more risk factor for OSA. Then narrowing of hard palate. These are risk factor of OSA. So we have to assess whether patient may have OSA or not. So you can try in your home also. So if you have risk factor for OSA, then we have to assess for OSA. Okay, so we have to ask 8 questions. We have to assess 8 things to label whether patient have high suspicious of OSA or not. So what are the 8 questions? Snoring. If patient is snoring, then factor 1. Tiredness, observed apnea, blood pressure. If patient is hypertension, this is risk. High BMI means obese, BMI more than 35. Age, if age is 50-year-old or more. Neck size is more than 40 centimeter. Gender male. If you answer 3 questions or more, then there is high risk for OSA. So low risk of OSA if less than 3 items, yes. If more than three, high risk of OSA. If patient is high risk of OSA, we have to evaluate positively and we have to treat patient. Otherwise, patient have many complications. If you not treat the patient, then patient will have complication. Patient may die. So what are the complications? As I mentioned earlier, drowsy driving, motor vehicle accident, neuropsychiatric dysfunction, memory loss, not able to concentrate, cognitive deficit, cardiovascular, sudden heart attack, congestive heart failure, arrhythmia, stroke, pulmonary hypertension, metabolic syndrome, type 2 diabetes, and non-alcoholic fatty liver disease, especially in female. So in female, if you found liver cirrhosis, then you should suspect of OSA. In OSA patient, if you not treat, patient may will develop liver cirrhosis even without alcohol. So these are the complications. So if you found OSA patient, you have to diagnose, you have to treat. Now question is how to diagnose a patient of OSA. So for diagnosis, we have to do sleep study, or in technical term we called polysomnography. In polysomnography, patient have to sleep in that sleep lab, and we used to attach various leads, various sensors like EEG. We will attach some sensor in head for sleep purpose. How much sleep is having patient? Patient snoring sensor, now belt, abdominal belt, thoracic belt, abdominal belt for oxygen saturation. So many leads we have to attach to a patient for recording. So for recording, what we have to record? we have to see sleep architecture, whether non-REM sleep is more, REM sleep is more, at what time what sleep is more, sleep efficiency, how much time patient is get up means awake, how much time patient is deep sleep, superficial sleep, how much patient having apnea, complete blockage of air, reduction in airflow, hypopnea, snoring, how much snoring patient is having, and because of apnea hypopnea, how much dip in oxygen saturation. Normal is anyhow more than 90%. So below 90%, how much? So oxygen desaturation, minimum SpO2, how much time the patient is having saturation less than 90, heart rate, blood pressure, and leg movements. So these parameters we have to observe while doing sleep study. So based on apnea and hypopnea, OS is divided into mild, moderate, severe. So EHI is apnea hypopnea index. So in 1 hour, how much time patient have apnea plus hypopnea? If it is less than 5, that is normal. Normal person can have less than 5 EHI. If it is 5 to 15, means in 1 hour, patient is having 15 times apnea plus hypopnea. That is mild OSA. Moderate OSA is 16 to 30. Severe is more than 30. So this is classification mild, moderate, severe. Now coming to management. How to treat patient of OSA. So far you have learned what is OSA, what are the symptoms, what is the complication. If you not treat the OSA patient, what will happen? Now, how to manage a patient of OSA. So OSA, surgical management, if patient is having, say for example, tonsils, you remove tonsils. If patient have that DNS, nasal septum deviation, you can correct it. Dental management, few patients, they have that teeth problem, you can correct it. But the main management is medical management. So in medical management, the main treatment is PAP therapy. I'll discuss later. So in medical management, patient used to ask, what is the treatment? If is there any drug? So let me tell you, there is no drug which cure your OSA. So recently, just 2 months back, there is one drug discovered which help in OSA, but this is not there in India. So by large, there is no medication, no drugs, no injection which treat the OSA patient. So what is the treatment? First, we have to ask for weight loss. So we have to ask patient for weight loss, and for weight loss, you have to mention that it is good to do weight loss exercise, but weight loss alone is not sufficient. So it will not cure your OSA, but weight loss will reduce your pressure requirement. Okay, and remember that weight loss is not easy in OSA patient. OSA patient weight is like a stubborn. Okay, it will not get reduced easily. Very difficult to lose weight in OSA patient. Okay, so we have to advise. The main treatment is positive airway pressure therapy. Okay, so what is airway pressure therapy? We have to apply a mask. This is machine. We have to apply a mask which will give pressure. So first question is whom to treat. Is all patient need treatment? So answer is no. So any patient, those who have AHI of more than 15 or RDI, more than 50, then that patient require treatment definitely. Those patients who have mild OSA, AHI between 5 to 15, but they have symptoms. They have mild OSA, but they have symptoms like sleepiness, fatigue, insomnia, impaired sleep quality, breath holding, gasping, choking. So these patients require treatment. Even though they have mild OSA, but if they have symptoms, they require treatment. And that patient, those who are having critical job, critical attention job like pilot or drivers. In that patients who require more concentration, that patient, even there is mild disease, they need treatment even without symptoms, because there is job like that high risk job. If they will have daytime sleepiness, they may have accident. So to prevent this, we have to treat even in mild disease, pilot or drivers. So how CPAP works? CPAP means continuous positive airway pressure. Continuous. Okay. So what will happen in OSA? I told you that this is airway. So it will get obstruct in OSA patient. This back of tongue, it will obstruct, throat block. Okay. So once you apply pressure, once you apply mask and you will give pressure, air pressure, then it will help to open the air. So this is called pneumatic splinting. Pneumatic means air. So by air pressure, we are opening airway. We are opening throat. So once we will open the throat, the air will go inside. So this is mechanism how CPAP work in OSA patient. So it is giving pressure which is opening the air. Okay. So next question is how much pressure do I need and whether CPAP will be effective or not, because CPAP is something machine cost around 40,000, 50,000. So whether it will work or not, it will solve the problem or not. Once patient will purchase, it is not easy to refund. So we have to make sure that it will work patient or not, and how much pressure we have to set in pressure. So for that we have to do titration study. So in titration study, what we do, titration can be done in hospital or can be done in home also. Okay. In hospital, what we do, we have to repeat our sleep study with this machine. This is CPAP machine. So we have to apply CPAP with nasal mask. Okay. So we have to attach all lead like EEG lead, snoring lead, chest belt, oxygen. We have to apply all leads and we have to apply CPAP pressure. We have to give pressure by nasal mask or oronasal. Okay. By applying pressure, we have to see is there any difference in sleep, deep versus superficial sleep, there's any improvement in sleep efficacy, improvement in apnea, hypopnea, snoring, improvement in oxygen. So we have to monitor all these things with CPAP, whether it will give benefit to patient or not. Heart rate, blood pressure, leg movement. So by machine, it should get improved. Then only we have to prescribe CPAP machine. We can do titration at home also. For home, we have to use autopap machine. So what is the difference between CPAP and autopap? CPAP is giving continuous pressure, same pressure. If you set, say for example, 8 centimeter of water, whole night it will give 8 centimeter of pressure, whole night. But autopap, it will give different pressure, depends on requirement by patient. Say for example, if patient is lying supine, then pressure requirement is more. If patient will turn left or right, then pressure requirement will get reduced. So when pressure requirement will get reduced, it will give less pressure. If pressure requirement is more, then it will give more pressure. So autopap is giving different pressure, less or more depends on requirement of patient. Okay. For home titration, we have to give autopap for 1 to 2 weeks. And after 1 to 2 weeks, we have to download the data from machine. And by we have to observe in 1 to 2 weeks whether patient that improvement is there or not. Apnea, how much hypopnea, how much oxygen, all have improved or not. We have to observe closely. Okay, if we are satisfied, then we can prescribe machine. So which is better, autopap or CPAP? So study says both are equally good for relieving the symptoms. So for treatment of OSA, both are good, but autopep is better tolerable for patient. So by efficacy for that symptoms relief, both are equal. But if you ask choice from patient, then autopep will be preferred because autopep pressure automatically changes. So autopep is better as compared to CPAP for compliance. But for efficacy, both are equal. Something is called BiPAP. BiPAP means two pressure. Bi means two pressure. Inspiratory more pressure, expiratory less pressure. There are two pressure, different pressure. In previous auto CPAP or CPAP, same pressure while inspiring and expiration. But here is two pressure. So we have to prescribe BPAP in patient those who failed for CPAP and APAP, or CPAP pressure is more than 20. If we are giving C pressure more than 20, patient will not tolerate. We have to give BiPAP. Those patients who are having OHS, which means obesity hypoventilation syndrome, in that the patient will have more CO2. For CO2 washout, we have to use BiPAP. OSA with COPD, OSA with neuromuscular disease like respiratory failure, central sleep apnea. So these are the indication for BiPAP. Now interfaces. So what's the mean of interfaces? The mask, what we are using. So there are three things: machine, tubing, pipe, and the mask. So machine will give pressure, and by mask, pressure will go inside. So it is many interfaces like nasal mask. So this is nasal mask. The pressure giving through nose. The problem is the it will cause some ulceration here because we are giving pressure like now. It will press here. It will give ulceration here. Okay. Another nasal pillow. So nasal pillow is like a nasal calendar, but we are giving oxygen na nasal pillow. So it is getting inside. The benefit is that there is no strip on nose, so there is no ulceration on nose. Okay, so giving direct pressure here. The problem is that we cannot give high pressure by this. We can give only 8 to 10 centimeter of water pressure by this nasal flow. If patient requirement is more than 10, then we have to give mask only. So this is nasal flow. Then oronasal mask. So if patient is sleeping by opening mouth, suppose we are giving nasal mask and patient open his mouth, then we are giving pressure here, but it will leak from mouth. So in that case, we have to give oronasal mask. Okay, it will cover both nose and mouth. So it will give pressure from both sides. Okay, so it is good, but the best is nasal mask, because once you apply nasal mask, then patient that mouth will be free. Patient can speak, patient can expectorate, patient can spit, patient can eat, patient can drink. So nasal mask is used most frequently as compared to oronasal mask. So there are many problems with interfaces, like most of the time this discomfort, because once you apply mask, no, it will cause difficulty. Skin erythema, claustrophobia, nasal ulceration here, ear pressure, nasal congestion, because it will pressure inside the nose, no, so it will cause nasal congestion, severe ear pain, nasal dryness, eye irritation because pressure goes inside the eyes, gastric insufflation, ear leaks. So many problems are there, but we have to counsel patient, we have to see, and we have to handle all these complications. We have to make patient understand that this problem will come, but we have to use CPAP. We have to use CPAP, then only patient will get benefit. So what are the question patient used to ask? So how many hours we have to use CPAP? Once you prescribe CPAP, how many hours? So minimum patient has to use 7 hours per night. By default, we have to tell. So you have to apply whole night. If you are sleeping for 8 hours, you have to apply 8 hours. If you are sleeping 7 hours, you have to 7 hours. But best result if you use 7 hours per night. daily. Patient has to use daily. Another question, how long should I use? 1 month, 2 month, 4 month, 1 year? How long? So you have to tell patient that your problem is permanent. Your muscle weakness, your tongue, all is permanent. So you have to use long time, lifetime. You have to use lifetime. Even if you lose the weight, then also you have to use CPAP for your uh, problem. Then other question is, if I don't use 2 to 3 days when I travel, common question. Suppose I am going Bombay or Delhi. If I am not used, what will happen? So we have to tell that whenever you will not use this machine, your symptom will reoccur. You will have excessive daytime sleeping, you have snoring, you have fatigue, tiredness, all problem you will have. So you have to use daily. And traveling is no problem because machine is small size like a stabilizer. Okay. So you have to carry, and flight person they allow. So you can take with you with your luggage on your handbag. So you have to carry your CPAP along with whenever you go anywhere. Okay. So if I lose weight, can BiPAP or CPAP can be removed? No. Is no or very less like, because this is your genetic problem because of muscles problem. Okay. So if you lose weight, the pressure required may be less, but you have to use CPAP whole life. Weight reduction will not remove your CPAP. Pressure may be pressure requirement may be decrease, but you have to use CPAP. Then only it will be good for you. So this is example of my patient. We have prescribed CPAP for this patient, and he was using for 3 months. We have followed after 3 months, and he was using more than 6 hours per night. After 3 months, his diabetes well controlled, hypertension well controlled with treatment. Previously, it was not getting controlled. Diabetes was very high, sugar level was high. But once he used CPAP, his diabetes get controlled within 3 months. Excessive daytime symptoms gone 100%. He was feeling fresh at daytime. He was doing his job very nicely. He was not getting sleep at daytime. He was working perfectly. He was so happy with treatment. He told in Hindi that मेरी लाइफ चेंज हो गई, पता नहीं अब तक मैं कैसे जी रहा था. My life has been changed completely. I don't know how was I living so far. I came from hell to heaven. Now I am living in heaven. I was there in uh, hell. So this is the word of patient. So believe me, CPAP treatment, if you prescribe correctly, if patient take correctly for adequate duration, adequate pressure, it will change the life of patient. Patient will be so happy. It will change completely. His diabetes will get control, hypertension, heart failure, all will get control. This is very gold standard treatment, and there is no side effect, as there is no drugs, no side effect. And more than him, his wife was more happy. Why? Because patient was having snoring that before CPAP therapy, and because of snoring, wife was not sleeping. So wife was not sleeping, and he was having tiredness whole daytime. But once he got CPAP treatment, his wife was sleeping very nicely. He was equally happy, even more than happy than patient, because now he was having adequate sleep. So CPAP treatment not only treat patient but also treat family members. This is very good treatment. We have to give treatment to all OSA patients, those who are having symptoms. Okay. So to summarize, we have to counsel patient about OSA. We have to tell why OSA developed, what the symptoms of OSA, and what is the complication. Complication, if you will not get treatment of OSA, you will have diabetes, you will have hypertension, you have heart attack, you have a stroke, you have osteoporosis, you have many complications if you not treat the OSA patient. We have to counsel patient. Then only patient will accept treatment. Main treatment is PEP treatment. There's no medication, no drugs, no injection. We have to advise lifestyle modification also, like weight loss, regular exercise. We have to avoid alcohol because alcohol further reduces the tone of muscles. So we have to avoid alcohol, sedative use, and we have to use PEP therapy. But before prescribing PEP therapy, we have to tell how PEP therapy work, what is the mechanism, what interfaces. We have to troubleshoot. We have to follow up regularly patient every 3 months or every 2 months, and we have to confirm that patient is taking adequate CPAP therapy or not. So this is a very good effective treatment, but patient has to take daily, adequate pressure, adequate duration. Regular follow-up needed, because if you prescribe CPAP, no, then patient will quit after 1 month, 2 months, 3 months. Patient will get relaxed, but you have to do regular follow-up. You have to check adherence of PAP. You have to see what is the problem in taking CPAP. Okay, then only patient will take. So that's all from my side. If you like this video, please share with your friends, and share with your friends who need, who have OSA and need treatment. So see you with another video. Thank you very much.